Economic reasons to expand HCV screening and treatment. The best teams of scientists and healthcare professionals from around our planet work together to explore, understand, and discover new worlds of treatment and care. In 1989, the hepatitis C virus, known as HCV, was discovered. It is a blood-borne virus that has progressively been infecting the general population. A large percentage of HCV-infected patients are adults of working age. Patients infected with HCV have a higher expected risk of developing liver complications over a lifetime in the absence of treatment. 78% are predicted to develop compensated cirrhosis, 30% are expected to develop decompensated cirrhosis, and 16% are expected to develop liver cancer. While more than 7% of the HCV-infected population are anticipated to have a liver transplant, the need for transplantation may actually exceed this figure. If HCV patients are not treated, 1 in 3 are expected to die from liver-related complications. Aside from the burden on patients and their loved ones, HCV poses a significant economic burden for our planet's healthcare system. In the United States alone, $19 billion are spent each year on HCV management for baby boomers. Of this annual healthcare spending, only 1/3 is used to manage patients with compensated cirrhosis and end-stage liver diseases. $12.4 billion, or 2/3 of annual spending, are allocated to manage HCV patients in the earlier stages of the disease. In addition, HCV severely impacts work productivity. A study has estimated that HCV-infected employees experience a productivity loss through absenteeism that is 60% higher than their non-infected counterparts. Due to the lack of efficacious treatments historically, when cure rates with interferon-based regimes were at 45% or lower, payers had limited cause to allocate resources to treat all HCV patients. As a result, treatment has typically been restricted to patients in advanced stages of liver fibrosis. If patients in the early stages of fibrosis are left untreated, the incidence of hepatocellular carcinoma and decompensated cirrhosis would continue to increase in the years ahead. This phenomenon is visible across all parts of the planet. It would also increase the economic burden of HCV. What actions can we take to reduce the clinical and economic burdens of HCV? Recent DAA therapies have achieved a breakthrough in HCV treatment, reaching cure rates of 90 to 100%. However, in the current status quo, HCV treatment is generally restricted to F3 and F4 fibrosis stages only. Limiting treatment to F3 and F4 patients, even using the new DAA therapies, would only marginally reduce the total number of infected patients. While the new DAA therapies significantly improve cure rates, reducing the total number of infected HCV patients is only possible with appropriate funding and access to treatment. What if we went beyond our current status quo? What if we treated all patients irrespective of the stage of their disease and implemented a comprehensive national HCV strategy to cure and control HCV? What would that reality be like for patients and payers? Only by treating all HCV-infected patients with the new DAA therapies can the prevalence of HCV in a society be significantly reduced. Studies show that comprehensive treatment would have the same positive effect in multiple countries across the planet. The burden of HCV is made worse by the fact that many patients are unaware of their HCV infection. In fact, up to 75% of people infected with HCV may not be aware of their infection. As such, the successful reduction of HCV prevalence in a society also requires more patients to be screened. Studies show that if more patients are screened and all disease stages are treated, a remarkable effect on costs to manage HCV can be seen. The time needed for the investments in HCV treatment to be fully recovered through savings in HCV healthcare spending and improved patient health would be shortened. With the current HCV treatment paradigm, this break-even point is expected to occur in 20 years, in addition to the projected health burden to HCV patients. But when screening is expanded and all fibrosis stages are treated, the time to break even can be achieved within just 8 years, thanks to reduced healthcare spending on liver-related complications and improved patient health. So this approach is also cost-saving after 8 years compared to a more restrictive treatment approach. Effective HCV treatment is an investment, not an expense. Expanding the treated population not only cures more patients, it also saves healthcare funds. What's more, it brings additional benefits for society. For example, it significantly reduces the HCV-related demand for liver transplants, leading to 10,000 livers being spared over the next 20 years in the United States alone. 7 out of every 10 of these will then benefit non-HCV patients. It may increase employment rates and productivity, helping patients get back to work and independently provide for themselves and their families. It helps save healthcare resources to treat other diseases. We have a commitment to improve the lives of patients living with HCV and ease the clinical and economic burden of HCV on the whole of our society. By linking screening with access to care through a national HCV strategy, we can achieve our shared ultimate ambition: to free our planet from HCV.